Hello, everybody. This is a bit weird, isn't it? It's certainly not the way that I had envisaged this debate with Yvonne around a topic that is really important and is really close to my heart. So the question for today is whether hand hygiene audits should be performed routinely in hospitals, and I'll be making the case based on some published evidence of my own experience that the answer must be emphatically yes. My name is John Otter. I'm the manager of the infection control team at the Imperial Group of Hospitals in London. I also work at the college doing some research from time to time. I have a few disclosures, none of which I think are particularly relevant to the debate today. Oh, that's weird. How did that get into these slides? Must be a mistake. So before we get down to the detail, let's just analyze the question and define our terms, which is important to do during any kind of debate. So what do we mean by hand hygiene? So the cleaning or disinfection of hands using either soap and water or alcohol or non-alcohol containing gel. What do we mean by audit? Well, we're really talking about clinical audit. So to find out whether a service or a provision in a healthcare setting is in line with the defined standard, and in order to kickstart improvement, if not. What do we mean by routinely? Now, this could be important in how we vote at the end of this debate. What I mean by routinely is not a one-off, so not related to, for example, an outbreak investigation, but has a set frequency, something like weekly, monthly, annually. I'm not too bothered about how frequently routine is. And finally, what do we mean in hospitals? Well, simply put, it could be a big one or a small one, but any acute care provider, secondary, tertiary services, providing inpatient care. That's the kind of setting that I'm talking about here. So these are the four key parts of my argument. Firstly, some evidence from the published literature that hand hygiene is really important. Secondly, a little bit about the what, the where, the who, the how of the audit itself. Thirdly, that whether we like it or not, it's a regulatory requirement. And finally, some details of my own experience of an improvement journey. Let's begin by looking at some of the published evidence that hand hygiene is really important. So cast your minds back to the 1960s, and what you'd really like to see is a randomized controlled trial of a patient group where hand hygiene was done and a patient group where hand hygiene was not done. And believe it or not, this study has been done. It would never get through an ethics committee today, but the study was the randomization of hand hygiene in a neonatal unit of all places. And what they found was the babies who were handled with hand hygiene were half as likely to acquire the organisms of interest in this study than those who were handled, believe it or not, without hand hygiene. Now, I'm not suggesting for a moment that we should replicate these data, but it's a powerful example of just how important hand hygiene is in maximizing patient care. This is an image of a fire that happened in a pit lane of the German Grand Prix in the 1990s, and it's Jos Verstappen in the car. I'm pleased to say that he and his mechanics were absolutely fine. The reason I'm including it here is I wish this happened when a hand hygiene opportunity was missed. Let me explain what I mean. When hand hygiene opportunities are missed, transmission can occur, but the problem is you don't see that transmission immediately. It can take weeks, maybe even months for anything to actually manifest following a transmission related to poor hand hygiene. What if, when hand hygiene was missed, this happened? What a powerful aid memoir that would be to a healthcare worker. And it means we're working in a behavioral science context. This is some famous data from Semmelweis in the 1800s, demonstrating the impact of implementing chlorine wash in between the mortuary and the delivery suite, and you can see the rate of peripheral sepsis drop dramatically as a result of this intervention. In much more recent times, using methodology that we would recognize more clearly, the study from Geneva in Switzerland showing that improvements in hand hygiene resulted in significant and progressive improvements in the rate of healthcare-associated infection during the same period. So to summarize then, we know from lots of studies that hands become contaminated during patient care. If you don't wash your hands, they transmit between patients. That if we do hand hygiene, that reduces significantly the microbial burden on hands, and that this results in fewer healthcare associated infections. We also have emerging data that hand hygiene improvements in patients can result in improved outcomes. And I would point you towards the WHO guidelines on hand hygiene and a number of Cochrane reviews, which summarize nicely the evidence of the importance of hand hygiene in maximizing patient care. Okay, let's move on to talk about which audit to use, which standards to use, and why this is important in the context of our debate. So we need to address head-on the issue of sources of bias that occur during hand hygiene auditing. I could think of 3 key sources of bias that occur commonly during hand hygiene auditing, and by the way, during many other audits. The first is observation bias, also known as the Hawthorne effect, not, by the way, coined by a person called Hawthorne, but due to some observations that were done in a factory in Hawthorne in the US related to manufacturing. So the Hawthorne effect. Behavior is modified simply by the awareness of being observed. If I stand over your shoulder with a clipboard, you're more likely to do hand hygiene than not. Observer bias. This is the difference between the true value and the observed value related to observer variation. So if you have very poorly trained observers working in a clinical setting observing hand hygiene, you're likely to see significant observer bias. And finally, selection bias. This is when a selected group or data does not correspond to the population mean. It doesn't represent the population. So this would occur if you base your observations on too smaller sample size, if you make inferences based on 2 hand hygiene observations on hand hygiene performance in a whole organization, or equally if you perform hand hygiene at one point in the day, every day, and assume that that's representative of hand hygiene all the time throughout the day. Those are 2 examples of where selection bias may be a problem in hand hygiene auditing. We can go a long way in reducing these types of bias during hand hygiene auditing. I won't say that we can eliminate them because we can't, it's not possible, but we can certainly go some way in making methodological improvements in reducing them. So what to audit? We could do a hand hygiene audit of a number of things, most commonly direct observation of staff performing hand hygiene. Its ease of implementation isn't brilliant compared to other methods. You have to have properly trained auditors, a good sample size, a range of times to sample. And it is the most prone to different types of bias, including Hawthorne observer and selection bias. However, the evidence that it correlates with reduced healthcare associated infection is probably the strongest of all the different ways that we could audit hand hygiene. We could also do direct observation of patient hand hygiene, which is subject to a similar profile to direct observation of staff hand hygiene, but the evidence that it correlates to reduced healthcare associated infection is less strong. We could also audit other related things. We could audit hand hygiene technique. We could audit hand hygiene facilities. We could audit product consumption as a proxy for hand hygiene, or we could audit hand hygiene using automated measurements with some newer technology. For the purposes of this debate, I'm not too worried about which aspect of hand hygiene that you decide to audit, but I would argue really that direct observation of staff hand hygiene should be a part of the way that you audit hand hygiene in a healthcare provider, not necessarily the only part. Related to this really then is which standard should we be using for our audit? Should we talk about moment 1, which is immediately before patient contact? It's the easiest moment to audit, but perhaps the most prone to bias as well. Should we audit only before a clean or aseptic procedure? There's some advantages to doing that, but getting a sample size that's big enough will be tricky that way. Should we just audit before and after patient contact? I saw a brilliant debate some years ago at one of the IPS conferences about whether we should audit all 5 moments or only moments 1 and 4 before and after. I think it was Didier Pité versus Michael Borge, and it was thoroughly entertaining. But for the purposes of this debate, not relevant, because both are types of hand hygiene audit. Should we instead audit all 5 moments of hand hygiene at the same time? Many would consider this the gold standard, and in many ways it is, and perhaps less prone to bias than some of the other moments. Whatever we decide to audit, whichever standard we audit against, it needs to be a performance indicator that can identify areas of poor performance and therefore drive focused improvement initiatives. And which targets should we have? You need to score 100%, right, in your hand hygiene audits? I think we need to be pragmatic and frankly get real. We know from pretty much any published data that's out there that hand hygiene compliance against the 5 moments for hand hygiene in a real world busy clinical environment is a long way off 100%, even if it's post improvement. The average hand hygiene compliance in a systematic review of almost 100 studies was about 40%, a little bit lower in the ICUs due to more moments for hand hygiene occurring there, a little bit higher on the general wards. We also see some consistent themes running in these studies. One is that hand hygiene amongst medical staff tends to be lower than amongst nursing staff, and we also see consistent differences in the proportion of the different moments for hand hygiene that are compliant. So we know slightly counterintuitively that hand hygiene immediately before patient contact is considerably lower than hand hygiene after touching a patient, moment 4. I think there's some really interesting psychology at play here. We are all into our own self-protection. We can't get away from that. Our brains are wired that way. So if we feel that we've contaminated our hands, for example, through patient contact or through contact with blood and body fluids, then we're much more likely to perform a hand hygiene. Whereas if we touch, for example, only the environment, the psychological trigger isn't there to say, yes, I need to perform a hand hygiene. There's also some really important modeling work which suggests that improving hand hygiene compliance above the 65 to 70% mark makes very little impact in reducing the transmission risk. So we need to think carefully and make an informed evidence-based decision about what our target should be for hand hygiene compliance in a healthcare provider, and it shouldn't be 100%. So how can we reduce bias and improve the accuracy of our hand hygiene auditing? We can do a number of things. So let's look first at the Hawthorne effect. The problem, remember here, is that the person being observed is more likely to do hand hygiene just by the very fact that they are being observed. So if we do covert auditing, a sneaky audit where we're pretending to do something else, but we are in fact hand hygiene auditing, then we see a truer picture of what's happening. We know the Hawthorne effect is time related. So the longer that you are there doing your hand hygiene audit, the worse the observation bias becomes. And I think the most effective way to mitigate the Hawthorne effect is through automation of hand hygiene. Putting a system that is continuously generating hand hygiene compliance data will give you the true picture of hand hygiene in a clinical area. What about observer bias then? This is where the recorded hand hygiene compliance is different to the true hand hygiene compliance due to differences between the observers. One problem here is the consistency of training and education that an observer may receive. So if we provide clear audited training, we will reduce observer bias. Another way of improving observer bias is through peer auditing. We know that members of staff who work for a particular unit are more likely to score compliance on that unit higher than if they go to an alien or a peer, should I say, unit or ward. And the third way, probably the most important way and certainly the hardest way, is to promote a culture of transparency around hand hygiene, auditing and reporting. Some hospitals, and to an extent the NHS, has got itself trapped in a culture of requiring 95 or 100% compliance with hand hygiene auditing. And we need to work together and find a way to challenge that, to make accuracy more important than target hitting. And finally, selection bias. How can we reduce that in our hand hygiene auditing methodology? Well, we can think about what an appropriate sample size would be. If we were planning to do a study, we wouldn't just go out there and start collecting data as much as we could. We'd think, okay, what do we need to do to get a statistically valid sample that represents the population? So we need to think along those lines when we're planning our auditing. Another way to do this is to vary the audit times so that we're getting a more representative picture of hand hygiene compliance on the unit, and also ideally randomize the selection of our units. There's a tendency perhaps to go to the units where the perception is that hand hygiene compliance is better, and therefore you are not getting a representative selection of data in order to give you a picture of hand hygiene compliance across the board. I'm going to give you a brief example of each of those three categories just to show you how this can work in practice. This was a study published earlier this year looking at reducing the Hawthorne effect through covert observation. It was done in a 24-bed unit in Brazil with several different phases of the study, the first being overt observation, the second being covert observation, so in the same unit. And they found that indeed, as you might expect, the covert observers found a significantly lower level of compliance with hand hygiene, and I would argue a more realistic picture of actual practice related to hand hygiene in the unit for all but one of the moments of hand hygiene. Secondly, reducing observer bias. This is a study showing that trained observers working on hand hygiene auditing over a 3-year period in a Korean hospital consistently returned a lower level of compliance with hand hygiene. And that's what you want to see, because that's likely to be a much truer picture of hand hygiene and a much better starting place for improvement work. And finally, reducing selection bias. This is a really important study published some years ago in an American journal, and what it showed was the differences in the number of opportunities for hand hygiene that occurred throughout different periods of the day. And they then played with a little bit of modeling work to understand what the capture rate would be in terms of the number of hand hygiene moments, and also the number of staff that would be captured performing hand hygiene if they looked at, for example, a single block of 60 minutes versus 4 blocks of 15 minutes throughout a shift. And they found that more frequent, shorter blocks of hand hygiene resulted in a more accurate picture of hand hygiene compliance in the unit. Well worth a read when we're planning our hand hygiene auditing. Okay, I'm going to talk now about the regulatory requirements of hand hygiene. I'm going to use England as an example, but wherever you are working, it's very likely that you will have similar regulatory and probably legal mandates for hand hygiene auditing, and that can't be overlooked. Let's start with the Health and Social Care Act. So this is the legal framework for the provision of healthcare in England, and it's very clear that policies should be available on evidence-based guidelines, including those on hand hygiene at the point of care, and that compliance with these policies should be audited. Secondly, the NICE clinical standard, quality standard for IPC, says quite clearly that people who receive healthcare from healthcare workers should receive it from healthcare workers who decontaminate their hands immediately before and after every episode of direct contact or care, and that we should have evidence of local arrangements to ensure that regular local hand hygiene observation audits are undertaken. This is just an example of a CQC report from a hospital, published very recently, just before COVID in December 19. And one of the reasons that this service was classified as requiring improvement was because the provider did not carry out any hand hygiene audits of staff. And finally, fairly recently, NHS Improvement has published a national standard for infection prevention control, and this states that organisations must have systems and resources to implement and monitor compliance with infection prevention control as specified in this policy, which is about hand hygiene in all patient care areas. Okay, so in our last 10 minutes, I'd like to give you an improvement journey. And this is where we started. It's a lovely green sea, a sea of green. All of our indicators were perfect. Hand hygiene compliance was monitored weekly by ward-based staff, and compliance was routinely at the greater than 95%, in fact, very close to 100%. This is an excerpt from our annual report in 2016-17. However, we knew from the published literature this was unlikely to be a representative picture of true hand hygiene performance. So we decided this was something that needed to change. And it took us a while to do this, over several years. So we began by collecting some data to show that the routinely collected data in the blue, 95, 100%, was not a true picture, because when we went in and did audits with trained IPC professionals in the same units at the same time, we came out with a different answer, with a mean compliance at 56% versus 98%. That was a useful starting point. So we then decided to have a bit of an amnesty to try and retrain all the auditors and go out and audit again. And the results, 100% carried on. We then tried to switch the audit standard we were using from 1 moment to the 5 moments of hand hygiene with another round of retraining, and the result, 100%. We had a third attempt, which was not only changing the audit standard, but also changing the way that we collected data. We stopped the weekly collection frequency, and we went for a much less frequent, a quarterly trust-wide audit that was collected in combination between IPC and staff from the wards, in order to try and generate meaningful data for action. And finally, we returned what we felt were meaningful and realistic compliance figures for the organisation. And this was in around about May 2008 time. So that allowed us to really start the journey with accurate audit and actionable data to launch an improvement project supported by some communications work. So what do we do to improve hand hygiene? We can do many things. We've got some great support from the WHO, from the Cochrane, from various other bodies, which have done a lot of work looking at what does improve hand hygiene. We need to have a multimodal approach. Probably focusing on a single intervention won't be enough. We need to do a number of things at the same time. And this is what we did. We tried to develop and promote the development of local ward-owned improvement plans. We worked closely with what we call the focus wards, who had the lowest audit results at the beginning of the programme, to create locally owned and developed improvement plans with the support of IPC and the improvement team. We also made some attempts to focus on improvement in specific staff groups. We were aware that some of the communications messages around our hospital were old-fashioned, maybe a little bit shouty. Stop, wash your hands. We did some staff group work and found that staff really didn't like that very much. They wanted to be reminded about hand hygiene rather than to be told they must do it right now. So we came up with a campaign that was based on some song lyrics that we modified to make them a bit hand hygiene-y. Gel your hands before you go, and others. What were some other good ones? Land of Soap and Glory. If you like it, you should have put some gel on it. That was another good one. Stop right now. Wash your hands something like that anyway, Spice Girls. So it was a bit of fun. Some people loved it, some people weren't so keen, but it got people talking about hand hygiene. And the impact, we were delighted to see that in the next round of audit, which was in November 18, these focus wards that began with the lowest levels had jumped up from 40% to more like 60%. And then we moved on and began working with some other wards, and we were delighted to see that over the next 2 audit points, those focus wards maintained their higher levels of hand hygiene performance than they had at baseline. So we were able to achieve sustainability of improvement, which is one of the hardest things to do. We also saw that within specific staff groups, hand hygiene compliance was addressed. We targeted the therapist staff, who started as one of the lowest performing staff groups and ended up as the highest performing staff group by the end of the program. Trust-wide, the picture and the improvement was more moderate, starting from around about 56%, climbing up to 63% by the end of the program. It was a fairly small, in terms of percentage point increase, but statistically significant improvement with an upward trajectory that we hope will continue once we begin this program again post-COVID. So in conclusion, I believe hand hygiene audits should be routinely performed in hospitals because we know that clinical audit is the best way to measure performance of a clinical service. Audit programs related to IPC practice are a legal and a regulatory requirement. We know that low levels of hand hygiene compliance are a warning sign that healthcare associated infections are imminent, and that good quality, accurate, routine hand hygiene audit data is the only way to launch a meaningful hand hygiene improvement program. Just before I sign off, I've tried to preempt a couple of arguments that Evonne might make, that I might make if I was arguing against the need for routine hand hygiene audits. So Evonne may say, well, I've got rubbish quality data, it's a sea of green, it's false reassurance, what's the point? This is worse than helpful. My response to that is sort out your auditing, reduce bias, improve accuracy to get that actionable information we need. You may argue that hand hygiene 5 moments isn't workable to implement an audit. Then audit something else. We could audit compliance before and after patient contact, even compliance just before patient contact. We can be flexible on which standard we use. Evonne may argue that hand hygiene audits are fundamentally flawed. Hawthorne effect, observer bias, selection bias, bias I haven't even talked about. I'd argue that, well, yes, but all audits, and research studies for that matter, are subject to bias, which we can minimize through optimizing methodology. And I believe you can minimize them to the extent that you can generate actionable information to prompt improvement. Evonne may say, what's the point of auditing hand hygiene compliance when we don't know anything about hand hygiene technique? Well, I'm easy. If you want to audit technique as a useful performance indicator, that may be the only thing you audit, but it's still a hand hygiene audit. Evonne may say there's no good evidence that improving hand hygiene compliance reduces healthcare associated infection. Well, I don't think that would be fair. We have plenty of evidence. It's a no-brainer that improving hand hygiene will reduce healthcare associated infection. We do have some good quality evidence, albeit published many years ago in some cases. And really, who's going to fund an RCT or approve it ethically, where you might randomize whether or not you do hand hygiene? And finally, Evonne may argue that hand hygiene is only a proxy measure for healthcare associated infection. So why not just measure healthcare associated infection as an outcome? Well, I would argue that healthcare associated infection is difficult to measure accurately through routinely collected data. If you want to measure healthcare associated infection accurately, you need to provide, you need to do a research study to generate data as you go through, and it won't provide that actionable information that we need at the ward level. Finally, the ostrich. I think anybody who is going to make the case that you don't need routine hand hygiene audits in a hospital has got their head in the sand. A few brief acknowledgements before I finish. Firstly, the fantastic IPC team at Imperial, the improvement team, and the hand hygiene improvement group, which is a brilliant multidisciplinary group with clinicians and other healthcare workers and other staff from across our hospitals. So thank you to all those involved. And thank you for listening.